Hello everyone, I am Dr. Nikita Valluri, working as an assistant professor in Sridatta Institute of Pharmacy. So today now I am going to talk a topic called schizophrenia, which is a psychiatric disorder. Okay, so this comes under fourth unit of your portion. So what is schizophrenia? Coming to definition, it is defined as a complex chronic mental health disorder. Complex chronic mental health disorder characterized by an array of symptoms, like a group of symptoms, including delusions, hallucinations, disorganized speech or behavior, and impaired cognitive ability. So once again I'm repeating, schizophrenia is a complex chronic mental health disorder characterized by an array of symptoms including hallucinations, delusions, disorganized speech or behavior, and impaired cognitive ability. Coming to epidemiology, it affects more than 21 million people worldwide. So 1 in 2 living with schizophrenia does not receive any care for the condition. That means most of the patients, they will not be they are not taking any medications because of unnoticed, because as they are unnoticed. And more than 1.1% of USA population is affected by schizophrenia. And coming to prevalence, it seems to be equal both in men and women, that is both male and females. And the onset of symptoms occurs at an early age in males than in females. So the onset of getting this schizophrenia is very much early in males compared to females. And males tend to experience their first episode of schizophrenia in their early 20s. So as I said that they'll get so early, so they'll get their first episode like in the region of around 20 years of age. Whereas coming to women, they'll get their first episode in their late 20s or in early 30s. Coming to etiology, etiology is nothing. So genetical causes include it's genetic in origin is like 1%. Twins, they are at a risk of getting at 47%. So monozygotic twins, 47%, dizygotic twins, 12%, and once if the patients if there is a single parent who is schizophrenic, then there is a chance of getting 12% to that baby, 12% chances to get that next generation. And if two of their parents, both the parents are schizophrenic, then the tendency to get this schizophrenia is 40%. And first degree relative it is 12%, second degree relative it is 5 to 6%. So this is how genetical transformation takes place. Genetical population is like 1%, monozygotic twins 47%, dizygotic twins 12%, one schizophrenic parent 12%, two schizophrenic parents 40%, first degree relative 12%, second degree relative 5 to 6%. And viral hypothesis, that means a few viruses, infection with a particular virus also cause schizophrenia. It includes exposure to influenza virus. Exposure to influenza virus. And then immune dysfunctions. Immune dysfunctions, it includes anti-cardiolipin antibody and anti-nuclear antibody. So these two antibodies were increased in patients with schizophrenia in some, but not all the studies. So in some studies, it was found that anti-cardiolipin antibody and anti-nuclear antibody were raised, these antibodies cause destruction of certain neurons, which will control the normal functioning of a man. And two other markers, and apart from these anti-cardiolipin and anti-nuclear antibodies, other also involved, it includes impaired T lymphocyte proliferative response to mitogen, agglutinin, and impaired interleukin 2 production. So these were also have shown some alterations in patients with schizophrenia. And birth complications during delivery, birth complications including hypoxia. If there is hypoxia, it causes hippocampus and some neocortical regions are particularly have undergone any shortfall in oxygen in that conditions. And so the role of pregnancy and birth complications is also related to this schizophrenia, and that is termed as hypoxia-mediated damage. So when there is hypoxia during the time of delivery, a particular part of the brain or neurons gets damaged, causing schizophrenia. That is hypoxic-mediated damage. And then some studies suggest that the rate of obstetric complications are higher in early onset schizophrenia. Obstetric complications means during the pregnancy, the complications can be seen in early onset, and it occurs more often in males, in people with the prominent negative symptoms. Already, if they are having any negative symptoms and no family history of schizophrenia, so they are also at risk of getting this schizophrenia. And then coming to classification, so according to ICD-10, there were complete total 7 are there, but before that there are 5. The first is paranoid. That means the patient will be having delusions and hallucinations. Catatonic means unusual motor activity, extreme negativism, peculiar posturing. So that can be seen, that can be identified as classified as catatonic. And hebephrenic or disorganized. So it is also called as hebephrenic or disorganized. So it will be seen in the early age, that is disorganized speech, flat affect, hallucinations and delusions. And undifferentiated, that means schizophrenic symptoms that don't fit any diagnosis, that is called as undifferentiated. Residual, at least one episode of schizophrenia experienced in the past but no longer exhibiting signs of the disorder. Previously, once he has exhibited these signs of schizophrenia, but now there is no such kind of things, then we call it as residual schizophrenia. Paranoid, catatonic, disorganized, undifferentiated, and residual. Paranoid means delusions and hallucinations. Catatonic means movement will not be proper and extreme negativism can be seen. Disorganized means disorganized speech, disorganized walk, hallucinations and delusions are also seen. And undifferentiated, if the patient is behaving schizophrenic but doesn't come under any single kind of diagnosis, that is differentiated. And residual means previously, once in the past, he has experienced an episode of schizophrenia, but now at present, if he is not having any that kind of symptoms, then we call it as residual schizophrenia. Okay. And after that, according to ICD-10, other two subtypes also came. In that, post-schizophrenic depression. That means depressive episode after schizophrenic illness. So because of this schizophrenia, after this schizophrenic episode, they will feel depressed. That we call it as post-schizophrenic depression. And simple schizophrenia, that is progressive development of negative symptoms with no history of psychosis. Like slowly they will be always taking everything for negative, and that negative symptoms are seen, but there is no psychotic behavior, then we call it a simple schizophrenia. This is about classification of schizophrenia. And now coming to pathophysiology. So if you see any psychiatric disorders, not only schizophrenia, in all the psychiatric disorders, there is no exact or particular pathophysiology. Okay. So like these were all like some kind of assumptions or based on some studies, but there is no exact mechanism or exact pathophysiology as we have seen in other systems. Okay. So increased ventricular size, decreased gray matter have been reported. In most of the cases, it was found to be that there is increase in the ventricular size and decrease in the gray matter. So the theories of causation of schizophrenia, it includes genetic predisposition, obstetric complications, that means during the pregnancy if there are any complications, increased neuronal pruning, immune system abnormalities, neurodevelopmental changes, neurodegenerative theories, dopamine receptor defect, regional brain abnormalities including either hyper or hypoactivity of dopaminergic process. So these were considered as causes of schizophrenia, like abnormalities in the immune system, abnormalities in the dopamine receptors, and abnormalities in the neurological development, neurodegeneration. So because of these abnormalities, schizophrenia has been developed. So that was a particular theories. So different theories follows different things. So if you see that positive symptoms, so if the patient is complaining of positive symptoms, it is closely associated with dopamine receptor hyperactivity. Dopamine receptor hyperactivity can be seen in positive symptoms, and this dopamine receptor hyperactivity can be seen in mesocortex, whereas negative and cognitive symptoms may be closely related to dopamine receptor hypofunction in the prefrontal cortex. So once again I repeat, positive symptoms are due to dopamine hyperactivity, dopamine receptor hyperactivity, whereas negative symptoms and cognitive symptoms were due to dopamine receptor hypoactivity. So decreased activity causes negative and cognitive symptoms. Hyperactivity of dopamine receptors causes positive symptoms. Okay, and dopamine, so positive receptors that can be seen in mesocortex region, and the dopamine hypoactivity can be seen in the prefrontal cortex. And then this is all about dopamine receptors. And the other theory is glutaminergic dysfunction. So it says that a deficiency of glutaminergic activity produces symptoms similar to those of dopaminergic hyperactivity. Dopaminergic hyperactivity is seen in positive symptoms. So that means if there is deficiency of glutaminergic activity, decrease in the glutamate activity, then it causes positive symptoms. Okay. And then 5-HT abnormalities, 5-HT, that is 5-hydroxytryptamine, and also it is called as serotonin. So it was found to be higher blood levels of serotonin was seen in patients with abnormal scans in schizophrenic patients. These in serum serotonin levels were elevated. At the same time, they have increase in the ventricular size. So these two were there in related to serotonin. Okay. Coming to dopamine receptors, it is hyperactivity in positive and hypoactivity negative and cognitive. Glutaminergic activity, deficiency of glutaminergic activity more causes increase in the dopaminergic activity, but they are causing positive symptoms. And then serotonergic activity, high levels of serotonin is seen in schizophrenic patients, and also increase in the ventricular size was also identified. And then coming to clinical presentations, so in the acute episode, in that means sudden onset and severe episode, the symptoms include being out of touch with reality. So they will not accept the truth, and hallucinations, like they'll be complaining of they were hearing some kind of noises, voices of others, but there is no actually, which is not there actually. And delusions, fixed false beliefs. So whatever we say, they will not listen. So whatever they believe, that only they'll do, whether it is right or wrong, they'll not think about it. Just fixed false beliefs they'll be having. That is delusions. Hallucinations is they'll be hearing some voices. And then ideas of influence. So actions controlled by external influence, that is nothing but. And disconnected thought process. That means so they'll like for one thought and other thought there will not be any other connections. So they'll be thinking something which has no meaning at all. And ambivalence, that is contradictory thoughts. That means they only say that this is true and they only will say that wrong. So ambivalence, they will not come to a conclusion to one. They'll not stand on a single thing. So they will be fluctuating their moods and thoughts. Flat, inappropriate or labile affect. Autism, withdrawn and inwardly direct thinking. So they will be staying away from others, and inwardly directed thinking. That means they cannot think out of the box. That is autism. Uncooperativeness, they will not cooperate. Whatever they will do. If you stop them, they will become aggressive. Verbal or physical aggression. So they may abuse by saying some kind of bad words, or they may beat or do some kind of aggressive activities. So these kind of things can be seen in acute episodes. And impaired self-care skills, they were unable to do their own works. Disturbed sleep and appetite. So there will not be proper sleep and proper appetite. So these were the symptoms of acute episode. Being out of touch with reality, hallucinations, delusions, idea of influence, that means externally gets influenced by others' words, disconnected thought process, ambivalence, autism, uncooperativeness, verbal or physical aggression, impaired self-care skills, disturbed sleep and appetite. So these were the symptoms of acute episode. And after this acute episode, they will be having certain residual effects. So because of these previous activities and all, they will have a little bit of residual effects, residual features. It includes anxiety, suspiciousness. So they will be always suspecting others, lack of motivation, always feel so depressed, poor insight, impaired judgment, social withdrawal, difficulty in learning from experience, and poor self-care skills. So these were the features of residual effects, and that means after the psychotic or after the schizophrenic episode or acute episode, these would be the symptoms for a longer duration. And compound substance abuse. So if the patient is who is having schizophrenia, if he is having any substance abuse and non-adherence, then it will be very severe. So as we are saying that there are positive symptoms, negative symptoms, and cognitive dysfunction. So what all the things that comes under positive symptoms? Delusions, disorganized speech, hallucinations, behavioral disturbance, and illusions. So all this comes under positive symptoms. So when these positive symptoms gets, when there is hyperactivity of this dopamine receptors. And negative symptoms, alogia, that means poverty of speech, that means they may not speak properly or they'll use some kind of bad words when they are talking. Avolition, flat affect, anhedonia, and social isolation. So these comes under negative symptoms. Cognitive dysfunction, impaired attention, working memory, and like they'll not remember things properly, and difficulties in executive function, impaired attentions, and impairment in the executive of any function. So all this comes under cognitive dysfunction. So positive symptoms, negative symptoms, and cognitive dysfunction. And now coming to diagnosis. So there is a scale called Diagnostic and Statistical Manual of Mental Disorders 5th edition. So according to that, the criteria includes criteria A and criteria B. So if the symptoms continue or continue to the same, or if they persist for at least 6 months with at least 1 month of active phase, that means psychotic phase, so that comes under criteria A and may include prodromal and residual symptoms. So if the patient is having these kind of symptoms for at least 6 months, and out of these 6 months, at least 1 month, if they are like very active or psychotic psychotic phase, then it will be considered as criteria A. And it also includes prodromal or residual symptoms. So criteria A, for at least 1 month, there must be at least 2 of the following persistent for a significant portion of time. So in that 1 month, at least 2 episodes of psychotic behavior may be there. Delusions, hallucinations, disorganized speech, grossly disorganized or catatonic behavior, and negative symptoms. At least one symptom must be delusions. So out of all this, at least one symptom should be like delusions, hallucinations, or disorganized speech. Then that is considered as criteria A. Criteria B, significantly impaired functioning. So that will be considered as criteria B. So this is how the diagnosis will be done. So in the diagnosis, there are no particular blood tests, scannings and all. So depending on the patient's behavior, collection of this history from the patient, like how he is behaving and all, that information also should be collected from these patient attenders or patient caretakers. And depending on that only, major portion of the diagnosis depends upon. So this is all about this diagnosis of schizophrenia. So in the next class, we'll be discussing regarding the treatment of schizophrenia.